Good morning, everybody.
Good morning, Rachel.
Morning.
Good morning. I need a mirror in my office so I can comb my hair. I just came zooming in, literally zooming into the Zoom.
The Zoom is multi-purpose.
It is. Thank you, Evelyn.
Well, your hair looks great.
Well, it's still wet, so there you go. And it's freezing
Understood.
outside. What was I thinking? Somewhere in heaven, my mother's saying you're gonna catch your cold and die.
Mm-hmm. Good morning, everyone, and welcome to the Telemedicine Echo. My name is Beth Munson, and I am the coordinator for this Echo. I work for Missouri Telehealth Network and Show Me Echo at the University of Missouri in Columbia. I have the privilege of turning this over to our facilitator, Evelyn Nelson, and she's going to get us started. Hi, Evelyn.
Good morning, everybody. Happy February. It looks sunny and friendly outside, but then with a wicked bite. So we're so glad to have everybody joining this morning. I'm Evelyn Nelson with the Heartland Health Resource Center. Just a few house cleaning as we get rolling with the Echo this morning. First off, your microphones have been muted, but please do unmute as you have questions and comments. As well as please do type your name into the participant box so that then we can also have chat. We appreciate you keeping your cameras on so we can really connect with folks, but also understand if that's not possible for you this morning. And then just a reminder, everyone's been really great at filling out the surveys that have been sent out. And we're, with this being a piece of the collaborative, we're really interested to see what of those surveys is useful to you and your team. So just again, we appreciate your help with completing that information. With no further ado, let's get started. First off, I just want to introduce our hub team for the Telemedicine Echo. So this morning, I'll start with Rachel. Would you mind introducing yourself?
Hi, everybody. Rachel Mutrux from the Missouri Telehealth Network and Heartland Telehealth Resource Center here, and I'll be giving the presentation today. So I'll talk to you again in a second.
Thanks, Rachel. And Karen?
Good morning, everybody. I'm Karen Edison. I'm the Senior Medical Director for the Missouri Telehealth Network and our Show Me Echo program.
Super welcome, Karen. And Tim?
Good morning. I'm Tim Davis, Telehealth Manager at Oklahoma State University Center for Health Sciences and the HTRC Oklahoma representative.
Super, thanks, Tim. And Christy?
Hi, I'm Christy Gagne. I'm from the KU Medical Center, and I'm a telehealth communication manager there.
Super. And Robert?
Hi, everyone. Nice to meet you. I'm Robert Stiles with, I work with the Heartland Health Resource Center at KU School of Medicine, and sorry to be a couple minutes late.
No worries. And Chelsea?
Hello, can you see me?
Yes.
Okay.
Perfect.
Hi, I'm Chelsea with the Missouri Telehealth Network, and I work with Rachel and a few others here, and we're working on a telehealth project right now.
Super. And then finally, we're really pleased that our new Heartland Telehealth Resource Center Director is joining. So I know she's going to connect with many of you and learn from you. Molly.
Good morning, everybody. This is week 3 in my new role as the new program director for the HTRC. So welcome, and I look forward to learning alongside with you today.
Super, thank you. Well, I know we want to get rolling with Rachel's presentation. She's got a ton of great information to share. I wanted to give a little more introduction with Rachel because I know we know her work with Heartland, but she has a really impressive telemedicine and echo history. She joined Missouri Telehealth Network in 2002. As director, she's been responsible for setting the strategic goals for Missouri Telehealth Network, managing the day-to-day operations, and securing funding for MTN. In addition, she's been a real echo pioneer. She and her team have advanced a super echo, advanced really amazing work with autism and about almost every topic you can think of. And with many of the same strategies she's going to be talking about today. So thanks for sharing your expertise, Rachel.
Thank you, Evelyn. I am going to share my screen. Okay, does that look correct?
It does, yes.
Great, all right. So for those of you who have been joining us on the collaborative and for this whole term, this is kind of what our curriculum looks like, and we are in project planning right now. I hope I have these all in the right order, but we've got plenty of other topics. Some of these, I wanted to put this up here because some of these I'm going to touch on a little bit today, but not get really in depth to, because you're going to hear more about it in some of the other sessions that we have coming up. Okay, so the first thing I want to talk about when you're planning your project, you really need to have a good understanding about what the barriers are within your organization, but also within the broader context of doing telemedicine. And I made a short list here of some of the barriers that you might encounter, that you might think of already. But some of them you may not have thought of, and you want to make sure that these are on your list so that you can figure out how to work around the existing barriers or get some help in your organization in breaking those barriers down. So obviously we know broadband is a huge barrier in trying to get telemedicine in the home. You know, if we try to think about how to break that barrier down, we did that hotspot project last year for many of your patients. And we may be able to do projects like that again in the future. So as you think through the barriers, then also think through what am I going to do about it? So in the funding piece, we've talked about this some in this ECHO, but there's lots of federal dollars out there available for different grant programs to start new telehealth projects. And we have expertise here in the HTRC to help you think through how to write those grants. And there are lots of folks around our tri-state area that you could hire if you needed to help you write a grant. and some organizations that would offer you some of their expertise without charging you. If a barrier is knowledge about telehealth, and I would say this fairly broadly, whether it's people in your own organization or whether it's your patients, this is something that we have to tackle every day to try to figure out how to get more knowledge into the hands of people that need it. And that, I would say, that goes a little bit hand in hand with acceptance. And I know that many of you, that your organizations utilized telehealth during the height of the pandemic, but as soon as you started seeing patients again in person, that telehealth went way down. And some of your healthcare providers may not have thought that telehealth worked particularly well, or it wasn't well thought out and smooth as it needed to be. And so I think some of the experience that we had during the pandemic can help you think through and break down the acceptance barrier. Now, reimbursement, we've had talks on this. We'll continue to have talks on this. This is an ever-changing landscape, and every state you're going to have different issues and problems with it. Contracting, it depends on what type of organizational type you have, but you're going to have to contract for video conferencing equipment. You're going to have to contract sometimes for providers if you need to bring in outside specialists. Oftentimes you'll have to contract with, well, always broadband organizations, right? You have to make sure that you have enough, your own organization has enough broadband to support the telemedicine needs. So contracting is a really big issue. And so having an understanding of what should or shouldn't be in those contracts is a big deal. Luckily, we've got somebody partnered with the HTRC to help think through some of those questions. And organizational support seems to be a pretty consistent barrier across organizations. And I think part of it is just because we're all so busy doing everything else. Pandemic is a priority, everything is a priority. And so when everything is a priority, that means nothing is a priority, kind of. So you really have to figure out how to get telemedicine as a priority to build that organizational support in order to move forward. One of the things that is helpful when I think through a new telemedicine project is who's going to be providing telemedicine. Is it going to be literally everyone in your organization who can bill to see a patient? Or what about people that can't bill, like nurse care managers? Are they going to be using telemedicine? There are lots of new programs where maybe a certain type of healthcare provider wouldn't get paid for something, but in some cases they can, to provide different kinds of therapy or have different touch points within the system. So having a list of who is going to be using telemedicine in your organization is super important, because that's going to tell you, well, can we do this within our own organization, or do we need to contract with a different group to provide some of those services? So maybe your organization has to provide some type of service, but you don't have that service line within internally. So then you're gonna find someone else to do that. Alongside that is really understanding who your payer mix is. It's going to make a big difference when you try to think about what your first telehealth project is. You really need to understand how many Medicare versus Medicaid versus uninsured versus private you have. Some of those groups are going to make it easier to understand, and then some of them you're going to have to look at the contract and see what the contract says to know if you're going to be able to get paid. And sometimes the contract isn't even going to say it. You're going to have to go have meetings with different insurance companies and find out what they're going to pay for. Okay, so then who is working on your telehealth project? I think this is also just a great big issue that sometimes we don't think about, because organizations know that they want telehealth projects. They don't necessarily, it's like the chicken or the egg, right? So how do you hire somebody for a project that you're not sure if you're going to have funding for it, and you're not sure how you're going to move it forward, but you still know you want to start it. So sometimes people start it. Sorry, you guys, I'm trying to get rid of this thing on my screen. Sometimes you're going to have organizations that say, well, let's see what you can do. You know, go find a grant, get some money, get started, and then we'll see about finding some internal support and funding for you. But I would at least make sure that you can try to get top-down support for any project you do. Otherwise, let's say you get grant funding for it, and then the grant ends and you don't have a sustainability plan in place, and then that program can just sort of fizzle out. And it's almost like it didn't even happen if you didn't figure out how to sustain it. So once you kind of think that you're ready to get going on this, I think thinking about the low-hanging fruit, oftentimes it's in behavioral health because that is by far the most used service line in all of telemedicine. And then you can think about, well, what kind of project do I need to have? So for example, if you are going to provide telepsychiatry, but you don't have any psychiatrists, so you're going to farm that out to a different company to provide those services. Well, then do you have your patients come into clinic for that? Or can they see the patients from home? And I think that's going to depend on what the payer mix is and what's going to get funded. And it can get really tricky. So I think just thinking through what an easy win project might look like. Does it look like that you get this started and then after 1 year, can you expand based on the successes of your project? Or I think, making sure leadership understands what the goals of the project are and the timeline of the project so that you can give them regular report cards. And then thinking through who else can you use for reference on that type of project. I know here at MU Healthcare, Carrie Jones is on today, but they used a Mayo Clinic model when they decided to do some tele-NICU work. And it was really pretty in-depth because they met with folks from the Mayo to really learn about what worked and what didn't. So you're not just trying to recreate the wheel or make the same mistakes that other people have made. So when it comes to starting to build out a timeline, and let's say that you were going to write a grant. So these are all items that you could think about where they might go in your grant application, but that would work the same thing as if you're doing a project that you already have funding for. So you need to think about what programs you're going to use and try to be as specific as possible. Which clinics, what group of patients, which groups of providers, what modalities are you going to use? Are you going to use a hybrid model where you're doing some things through Store and Forward and some through Live Interactive, where maybe you're using the patient portal for part of this virtual healthcare project? You need to think through all the processes because it takes a long time to build some of these out within your billing system or within your scheduling system. So how do I build new telehealth modules within the current scheduling system? How are we going to do consent when it's over video? Who's going to provide training and who's going to build the protocols and who's going to provide the coordination? When we used to do telemedicine projects, we would have telehealth coordinators that would go across our organization and sit in on different clinics to make sure that things went smoothly. But if you have 30 different service lines, then you're going to build that coordination into those clinics themselves, right? You're not going to have a separate group of coordinators. So how does that work, and how does the funding for that work? Is it separate, or is it just the same way they do business every day? And then think about what groups of patients you're going to try to engage in your telehealth project. Do they need education about what is telehealth and what are their rights, or do they have to do telehealth? Is it their choice if they want to do telehealth or not? What is their willingness to try this technology? Do they have the broadband and other technologies that they need, something with a camera on it? And then how are you going to collect the copay, or are they expected to pay the copay? I think that that part is proven to be a challenge for many organizations, and think about how that would work if a patient is at home and you wanted them to pay a copay. Oops. When you're building your timeline, you also need to think about who are all of the partners that you need to work with ahead of time. So whether that's technology vendors, private telemedicine providers such as telepsychiatry companies, other hospitals, other healthcare organizations in which you might have to make sure that there are contracts in place. How are all the players involved going to get the training? And how do you agree on the processes between two different healthcare organizations, if that's the model you're using? So all these things need to be touched upon when you're building your timeline. And then as for the providers, I think everyone is well aware that there might be some readiness issues here with our healthcare providers on having regularly scheduled telemedicine. Are the telemedicine patients going to be scheduled just willy-nilly into every clinic, or is it a separate clinic that's just dedicated to telemedicine patients? That's been a big issue, especially in regards to space. So if you have a busy clinic and they want to see every other patient by telemedicine, do they use a regular clinic room for that? Or where do they go? Because in most cases, the clinic has almost like an open space for the healthcare providers. Sometimes they call it like a swamp. So they're going in there, and are they going to see patients when there are a bunch of healthcare providers in the background walking around? So how's that going to work? Is their documentation any different than it is when it's in person? Are there ERVUs associated with them seeing patients via telehealth? And then finally, the last group that you have to think about, and this gets touched on all the time, is how are your payers going to react to you seeing patients via telemedicine? I've always recommended that you look at your top 3 payers in your organizations and meet with them if needed. So you don't need to meet with Medicare or Medicaid probably, but with the top 3 private payers, they don't always publish their telemedicine reimbursement rules, and it's typically not in the contract that they're going to have with you. So you want to sit down with them and say, this is what our plan is. This is how many patients we think we're going to do through this visit or through this modality, and try to get an understanding where they're going to pay you. First of all, in Missouri, they have to pay you the same as they would pay you in person. But there is not a facility fee available in most cases for that. So your own organization needs to understand if revenues are going to change because you're going to get the provider fee, but not the facility fee. So I think I'm going to stop and open it and stop sharing and open it up to questions that you might have, or things that you want to talk about. And I can open that slide deck back up again if we need to. So when you saw some of the items on that list, what did it make you think about, Alex, in regards to your telemedicine project?
There, I finally figured out where the mute button was. Hello, it's nice to meet you. Thank you for your presentation. So, looking at that, we've gone through. We have a process that we figured out. We understand. Start off small, get the success, and then we can slowly build it out. But it's getting that initial, equipment and that space, dedicated that so the patient doesn't see people in the background, so on and so forth. So that's requiring a little extra funding that I don't have in my IT budget. And so, all these grants are for new implementations, but there aren't any for existing, or there's not many and for the ones that are, we don't meet because we're not currently doing it. So, since it's a new project, I mean, basically ground up, is that how we should look at it when going out and talking to vendors and contractors and so on and so forth?
Yeah, that's a good question, Alex. So I'm very familiar with SEMO Health Network. We partnered with them on projects in the past. I think it's a great organization, but it's definitely an organization that would fit many of the different federal funding programs to a T. It doesn't really matter that you did telemedicine in the past and now you want to do it again. So HRSA funding, USDA funding, Delta Regional Authority funding, all of those you're well qualified for. You just need and there are several organizations that could help you with the grant writing aspect of that. And I can send you a few names and help you start thinking through. I think one of the things that this group would do well, either all of us or a smaller group, is to help you sort of narrow down what in a nutshell, what does your project gonna do? And we can help advise you on that. And because you're part of the collaborative, we can do that offline. We can schedule time and meet with you to help you get a more concrete idea of what you would want to do across your organization.
Yeah, that's great. So it basically sounds like I haven't been looking in the right places or talking to the right people. So I appreciate that guidance, and I'll set something up offline with y'all.
Perfect. I know you've got my email.
Yes, ma'am.
Yes. Who else is thinking through this and thinking they're not quite sure where to go next? Or when you saw that presentation, was there part of it that surprised you? Michelle, from Nevada, I know you guys have been working on some different telemedicine projects. How are things going there?
They're going good. We've got a good program, I think, that was set up. So everything's going really good.
Was there anything that you would add to the list that I had created that we didn't have on there to think about that you've encountered?
No, everything that you had listed is right on track. I wouldn't add anything that looks real good.
Thanks. Who else?
Well, this is a little bit off topic, but a large percentages of our patient telemedicine visits happen when a patient has an appointment, face-to-face appointment, but then is diverted to the COVID hut because they're symptomatic or answer the survey question a little bit wrong. And as a result, that visit gets flipped to a virtual visit, and the patient receives their visit in the car. And while they're waiting in line to be tested for COVID. And so what's happened is most of our providers have dropped down to these ad hoc telemedicine visits because they can't go to a scheduled place or to a workstation that we've set up for telemedicine visits that are previously scheduled. They're dropping to Doximity, which has not only a dialer that all the physicians have been using for years, so that it portrays to the patient's phone their clinic number rather than their own personal phone that they're using. But the Doximity now has a free video line, so you can do the same thing with a video visit. So all those video visits now are dropping out of our system into Doximity. That was something that was not anticipated by any of our project plans, so to speak. And I'm wondering whether we need to figure out how to work some flexibility into our project management and project plans that allow for all of these type of visits that were technology-wise not possible when we designed the plan or not anticipated. And so you're finding a large percentage of your video visits for which they're being billed for telemedicine are outside of your normal trapping mechanisms. And so when you're reporting, it's a little bit different field, because if you report directly out of the scheduling system, none of these visits will be there. And so we have to drop down to using charges, and not everybody captures these charges with the correct modifiers. So we're finding a lot of stuff is bleeding out around the edges. And I don't know how to get your arms back around that. And so the question is, if anybody else had the same experience, and a lot more is going on than you're even aware of.
I think that's an interesting issue. Carrie, I know you're on, or you were on. Did you encounter anything like that? I'm looking through my next page to see if Carrie's still on. Maybe she's not.
I would just add, Rachel, that your healthcare providers, especially your doctors, are always going to default to the easiest frictionless thing if it's available. And it's not always the physician's top priority to make sure it gets counted, and so that's a problem. So you have to talk to them about it and say, in order to continue this kind of service, we have to be able to show our return on investment. We have to be able to show outcomes, and it really is important. The other opportunity is, they probably write a note, right? And so if there's some way you can, in your electronic health record, have some way to track and have them identify it as telehealth, that's another way to do it. But I think if they've got a frictionless way they're used to, and they've got it in their hand, and I think it occurs to me after last week's presentation that we ought to all kind of agree on coding for telehealth visits and what we're going to use and what we're going to count. I just throw that out there for discussion. Are we going to use the 2 and the 10, or what are we going to do? And wouldn't it make sense if we all did it the same together so that we could kind of record what we're doing in a more meaningful way?
If all of our providers were eligible providers, it would be one thing, but I'm working in a teaching institution. So none of our residents can bill because Medicare already pays for their salaries. So we hide or restrict their ability to place charges. And so the faculty have to place the charges. And so what usually winds up happening is that after this visit has happened that nobody really knows about, and the resident will then check out with the attending physician, it's up to the attending to help divert some of their attention to, okay, what was this visit, not on the clinical needs of the visit. And not oftentimes does the documentation reflect whether it was audio only or whether it was video. And so there are some errors that are hard to capture in the course of a busy shift, because most of us want to focus our attention on the clinical aspects rather than on the technology aspects. And this is starting to raise some interesting discussions as to why are we even spending time talking about the technology? It shouldn't matter, right? We didn't care what model of phone was used when we have a discussion with the patient on the phone. We did not care whether it was an AT&T phone or Verizon phone, whether it was a portable phone or whether it was an institutional phone or whether it was an Ericsson phone. We didn't care. It was all about the clinical content. And as a result, the attention was focused on the right thing. And I'm wondering if we're going through a phase in this whole telemedicine stuff that eventually the billing is going to matter on the content, not the medium. And this is especially true as we get into alternative payment mechanisms where there's a flat fee or a bundled fee or a prospective payment. And it doesn't matter, you know, we're not getting paid anymore whether it was audio only or whether it was face-to-face or whether it was high intensity, low intensity. None of the coding changes the payment because the payment's set in stone. And I'm wondering if probably a year from now, we won't matter. I'm just curious. And so writing projects for the future of this, I think we have to look forward to say, well, what is telemedicine going to look like 5 years from now? I'm just perplexed, especially as we look to writing grants and things like that. I keep wondering, why am I writing this grant when it probably that the whole technology may change by the time it's awarded?
Who's got a thought on that? I think it's too hard of a question, Dr. Varan, because no one is commenting. I think it is really interesting, but you know, we've seen the same thing reflected when we think about this from the federal level, because during the height of the pandemic, they said, we don't really care how you code anything, we're just going to pay for everything. And so that sort of gave people permission not to care about what was done in what modality. I do think from an organizational standpoint, it is very important to understand what your providers are doing and how they're doing it. And so the problem when we have one electronic system for billing and scheduling, one for the electronic health record, and then a third, for utilizing the telemedicine piece, is that you may have to build an imperfect system that looks across all three and does the best that it can. But at the same time, think through, simple, practical ways for both the residents and the attendings to say, yeah, this was a telemedicine visit. It seems like it shouldn't be that hard to have a click button in your electronic health record, and then figure out a way to pull that report so that you can see it. And I wonder, for those of you who are in teaching organizations, how are you thinking about these visits in regards to training, the next workforce? Are people just winging it, or are you providing any training for your residents to gear up for these telemedicine visits?
Hey, Rachel, this is Alex again. While we're not a teaching facility, it is one of the struggles that we've encountered while talking with our providers, is how are they going to go about an exam per se, with a patient, if it does require, a touch, vitals, things like that. So it is something that we've taken into consideration and looked at. So I know we're not the only ones, but it would be interesting to know how people handle prepping their providers.
I tell you, Alex, that's been a struggle teaching people how to do a proper exam with a video or virtual visit, because it takes much more time than it does in face-to-face. And one of the things that we've struggled with is when you do the video visit, you're doing a lot of the exam things without even thinking about it. And so the documentation, too many people run templates that just say this was a virtual visit and physical exam wasn't necessary, when in fact, they probably did a pretty good physical exam, but they're just not thinking in terms of actually laying their fingers on. So teaching them how to document what they did observe. An example came up yesterday when one of the residents says, well, I had a video visit with the patient and we couldn't do an exam. And I said, what do you mean? And I said, "Well, you've got the general portion of the exam." And she says, "Yeah, she was even smoking a cigarette while we were doing the encounter." And I said, "That needs to be in your note." You know? And there's a whole bunch of other things, but one area that really has cropped up lately is Apple Health. Apple Health has created a provider dashboard that is available to any organization in any EMR. And we turned that on about 3 months ago and started teaching our patients how to link those iPhone patients, which is about 50% of our patients, to open up and start sharing what's in Apple Health with us. And so when we do a video visit, that's the first tab we go to. And it's amazing because there are all your vitals, especially if they have a Bluetooth scale at home, if they have a thermometer or blood pressure cuff or anything that is Bluetooth connected. And it's surprising how many patients that do home blood pressuring, for example, have the newer cuffs all do Bluetooth, and they're going into their, say, Omron Connect or Walgreens or something like that. That funnels into Apple Health. And so just having that screen open, you can get most of the vitals and stuff like that for patients that are exploiting that connection. So I mean, there's a lot of neat things, so that if the person does have a smartphone and they're doing the visit with you, chances are they're running activity trackers, they're running a whole bunch of other stuff on that phone, and including that data as your exam portions or at various parts of the note, I think is critical.
Hello.
Yes, go ahead.
Yes, I'm sorry. This is Christina Bender from Advanced Psychiatric Services, and I don't know how on my phone to request to speak, so I apologize for just butting in. As I could say, we are psychiatrists, and it works a lot easier, I think, for us with the tele, because there's not as much that we need as far as equipment-wise to do an exam. But it has certainly been a lifesaver for our patients, not only with this COVID, what we see, and we're in a rural area and we border on a doctor poor area. So we're in a non-qualified plus a qualified. So for us, we're hoping they expand and leave both areas into qualify for tele, because our patients have been so much more stable. We haven't had any hospital admissions this year because we're able to see them. We can see them more often if they have a problem and take care of the problem. They're more compliant with their medications. But I understand, I think it's a lot easier for us in psychiatry versus if you're trying to do a medical visit.
Thank you for those comments, Christina. I really appreciate it. I think it's important. I see a question in the chat from Laura, who's talking about, are there people who can help the providers during the telemedicine visit? And I would say absolutely. There are lots of different models out there. And to David's question earlier about collecting information before the physician gets there, there are models where the patient goes into, sort of a waiting room, and the nurse would do the regular intake that they would do in person. So you can set these up to mimic the in-person visits if you have the staff, if you have the time, if you have, if that's what you choose to do. And so the nurse could be the one that's going into the Apple Health tab and taking all that information. And if it needs to be put over into the other health record because it doesn't flow, then you can do that too. So there are all kinds of models out there, and I think that's definitely one of them. But thank you for those comments.
And I'll just add to that, remember, there are two main drivers for getting your providers to keep doing telehealth. One is have a frictionless technology, for sure. And the second one is to have adequate support. And that kind of a model is that kind of support, having that support in terms of the clinical encounter.
So I'm looking at the chat and it looks, Laura's talks about, if you look in there, that in Texas, they have put together a medical school telemedicine curriculum. I think many medical schools are doing that right now, and it's important. And then also looking at residents and fellows practicing telemedicine and using the simulation lab. And many places are trying to get those types of projects up and running. David is saying that there are lots of patients with limited data plans. We've encountered this quite a bit. We did have a project that I mentioned earlier last year to get hotspots with unlimited data plans out in the hands of patients. And there were about 9,000 patients in Missouri that got those and utilized those for a significant period of time. And there's possibility that we can look to projects like that until or unless we get better broadband out to every patient. Heidi, do you want to tell us what your question is specifically about nursing homes? If she can unmute, or is she?
While we're waiting for Heidi, Rachel, there's also quite a lot of conversation and questions about audio only and the push for audio only. I don't know how much we've addressed that.
Go for it, Robert.
Well, just that, I mean, the hard thing to say is, yeah, I can understand why billing offices would be pushing not to do audio only. There are some changes specifically related to be able for audio only and some other things that will happen after the emergency. And then, of course, right now under CMS policy, under federal policy, audio only is allowed due to the public health emergency. Sounds like we've heard from a couple of people, or at least one, that Missouri Medicaid, there have been some issues with getting paid for audio only. So yeah, this inconsistency that we're seeing due to the COVID emergency and some of the things that were allowed that we found very useful, like the person who mentioned that many patients may not have video capability, so audio only is working well for them. You know, these are issues that we're going to have to face as we come to the end of the emergency, as well as states kind of revert to non-emergency policies, because these things will go away unless there are changes made at a policy level or really at a legislation level. And a lot of this stuff is in current legislation that's in Congress to open up these things that can't be opened up by CMS just by policy options. And the biggest thing that I would encourage people to do is to make sure that their legislators at the state and national level understand the access issues and the issues related to patients, you know, maybe only having these availabilities, as well as the benefits. In the end, a lot of this is going to come down to cost, right? And so also sharing any data you have on decreased costs. And right, when we talk about value-based care and where we're hopefully moving, where we're paying for health and rather than illness, these are the types of things that hopefully can, you know, be used to talk about this being cost effective, regardless of the idea that, you know, perhaps audio only isn't as good. We can talk about the quality, that we think it's as good quality, show that it's as good quality, can talk about issues of payment and that keeping people healthy is less expensive than finally seeing them when they're not ill. But these are the types of things that you should be talking because there's a lot of support for telehealth and continuing these things. And sometimes there's this idea that CMS doesn't want these changes, but CMS is limited by statute. And so some of these things like audio only are really limited because statutory changes need to happen. And there are many bills in Congress that are looking at changing these things. It just takes passing them. And I always mention, and you know, just as a final note on that, it's not as hard as people think, because anything that impacts spending or cost, right, is considered a budget issue. And budget has different rules or than other types of legislation. And secondly, some of these changes could just be happen by putting language into a budget bill, taking language from a bill that's out there and putting it into a budget bill, which is often how things like this happen. So not encouraging anyone to do anything or not do anything so much as just letting you know that these are the types of things that you should be letting the people who make the law and the people who I know, you know, Missouri, Kansas, Oklahoma, all have very strong senators and representatives when it comes to focusing on rural and frontier areas and the needs of them and how they differ. And that's a really good selling point when you talk about these types of innovations and the success you're seeing during COVID, during the public health emergency, maybe having that pass on into post-emergency.
Thanks for that, Robert. Heidi? Yeah, go ahead. Yeah.
Okay. I figured it out. So I just wondered if anybody had any experience with or knew anything about telemedicine in nursing homes. Because I'm the medical director for 4 nursing homes and have patients in about 8 different nursing homes. And as I don't know if you've noticed, I'm always in the car. And I am very much a rural doctor. I'm always on the road. Oh dear. I'm always on the go and traveling throughout Oklahoma. I'm on the road probably 4 hours a day, and really would benefit would really benefit from being able to do this via telemedicine. I mean, it would save me hours and hours a day.
Heidi,
Yeah.
Heidi, we need to have an offline conversation with you because I mean, I did teledermatology in nursing homes for decades. I mean, it's easy to do. And it's just a matter of setting it up, and we need to have an offline conversation with you about that.
Yeah, okay, because I work in a very small organization and there are only 3 doctors and there are 4 nurse practitioners and nobody has a clue. So it's me and nobody else. And so like I'm on my own, and I've been doing this every month since it started, but I've got no support network. I've got nobody, it's just me. So I'm doing
together with Tim and Rachel. Can we do that? And let's get together and let's have let's have an offline talk with you about that.
That would be phenomenal because I'm wearing down. Okay, thanks.
Well, to that point, Heidi, I used a portable kind of iPhone on a stick by a company 7 years ago now, to make nursing home rounds with that. And I could drive it with my own PC, but the nurses would always laugh that I was a very lousy driver. So they would just pick it up and walk from room to room to room as I made my nursing home rounds. And I could do that over the noon hour or something like that in between seeing patients. So there are solutions out there that work really well, have worked well for years.
Okay.
Well, I had a great conversation. Thank you for bringing that up. It looks like we're going to have a couple of offline meetings now with some of the folks in our collaborative and others. We're happy to do that. Part of what we do at the HTRC is to work with you in group settings like this, but also individual settings. So feel free to reach out to us and we are happy to schedule something. Evelyn, I'm just going to hand it back to you.
Super. Yes, but we really do want to connect with you offline. All these are super questions. I think what we can also do with our March meeting, if we have some folks who we're able to follow up with their permission, it'd be great to bring some of that information back to this group just to learn from the process and things that may bubble up as extra resources. We also looks like we had some great discussion with Tracy in the chat just around some of the audio only. I just wanted to add in, I think if we could get some of the evaluation data and those stories as well, where it does help a patient when snow and ice were an issue. I think some of those can be really compelling. I think I'm not seeing any other questions bubbling up in the chat. Please do keep in touch between now and the next session, because as this sparks interest, we really do want to hear from you. Our next session will be coming up in March. I'm sorry, I might ask Beth. I don't recall off the top of my head who's next up.
That's okay. The topic is provider engagement and training. And Robert Stiles has a guest speaker named Ryan Smith, and Karen Edison will be doing the presentation together.
Wonderful. Well, we hope to see you then.
Thank you, everyone. Goodbye.